Hi, thank you all for having me. As Stephen said, I'm Dr. Emily Choquette. I am the Emily from Roy's talk earlier, so he says that lovingly. I am an associate investigator and the newly appointed director of the Float Clinic and Research Center at the Laureate Institute for Brain Research. Again, as Roy liked to point out, I am a clinical psychologist, but what that means is that I do people research. He does germ research. But the difference between us is that I promise not to yell at you today. So, thank you for having me back. I am really excited to be here. It's particularly special this year. It's the 10th anniversary of the Float Clinic and Research Center at LIBOR. And it's also 70 years of float research in general. And I'm sure most of you know that. So I'm going to talk a little bit about the history and the evolution of float research. So thank you. I don't have any commercial disclosures. That's the science thing. So let's start off with everybody's burning question. I just said it's been 70 years. What is taking so long? What is taking so long? With technology today at the tips of our fingers and our cell phones, our computers, everything, we often jump to this eureka moment, this end of the scientific journey. Maybe it's the popular press article that you see where the FDA has approved a new treatment, or it's an insurance company saying, yes, we will pay for that. But what we don't see on the flip side is all of the years and years and years and studies that went into that eureka moment. And these broadly fall into three categories. The first is development. The second is clinical trials, and I'll talk a little bit more about these in a minute. And then the final stage is adaptation and implementation. Each of these stages can take years. And more importantly, every time we have a new clinical population we want to use this with, we have to replicate each stage. We can also think of the research progression as a pyramid. So each layer, providing the groundwork for the subsequent layers. So the first being development. Again, what is this intervention? What is this technology? What is the medication? What are the components of it? The second being clinical trials, and that's where I'll speak about today. Clinical trials have three phases. The first being, is it safe, and what are the effects of this intervention? The second being, does it work like I think it does? And the third being, how does it compare to other treatments that are already out there? And then finally, we get into adaptation and implementation, and that's, how do I take this into the real world? So, something also important to think about is that while this is a continuum and they build on each and its stages, it's more of a continuum. And so you'll see this in some of the clinical trials that I'll talk about, is that there's some overlap in these clinical trial phases. So in honor of the 70 years of float research that's been happening, I am going to discuss some of the mental health outcomes research. And I want to note that this is not a comprehensive review of all of the literature that's out there, but it's more a broad overview of what's been done first in clinically significant or clinical populations, so individuals with anxiety and anorexia nervosa, and it's in line with this framework to build float as an intervention for these mental health conditions. And then I have some exciting news about kind of some future float research that's happening now. So we got a history earlier today with Glenn, but I do want to just briefly kind of cover float history. So in 1954, Dr. John Lilly and Jay Shirley, who are both psychiatrists at the National Institute of Mental Health, created the first iteration of the float tank. And they used this to explore questions about how humans react to reduced sensory environments. In 1959, Dr. Shirley went on to build the first fully calibrated vertical immersion tank at the Oklahoma City VA. And subsequently, NASA actually used this to simulate space environments, which I think is just a cool fact. As many of you know, in 1973, Glenn Perry, in collaboration with Dr. John Lilly, invented the first horizontal float tank, the Samadhi tank, and later used that design when he and his wife, Lee, opened up their first commercial float center in 1977. Throughout the 80s and early 2000s, this horizontal float tank really revolutionized research in flotation-REST and allowed us to do more research, because people would actually get into these. And these studies primarily examined the physiological effects of flotation rest. And here you can see Dr. John Turner taking Dr. John Fine's blood pressure at the University of Toledo inside a samadhi tank. These 20 years of research culminated in this meta-analysis, which is a way to combine research to look at trends across research groups and research studies. And what they found was that flotation rest, again, primarily in healthy individuals, led to large reductions in stress. But this was the first signal that perhaps we can use this intervention in individuals that are diagnosed with clinical conditions. Jump forward to 2014, Dr. Justin Feinstein, in collaboration with Colin and Ginny Stanwell-Smith, the founders of Floataway, developed the open pool design here that you see. Designed this to be more comfortable for individuals with clinically elevated anxiety. Their specifications for these pools at LIBOR help to create the controlled environment that we need for research and the precise measurement that allows us to get our research results. So now that I've discussed some of the history, let's talk about the results of the studies. It's easy to say that the largest body of research that we have on flotation rest lies within anxiety. So specifically, I'm going to take a few minutes again to talk about studies that look at individuals with clinically diagnostic anxiety disorders, things like generalized anxiety and PTSD. And the first I'm going to talk about, lay the foundation for safety. Is this a safe intervention for individuals with clinically elevated anxiety? And then the others I'll talk about efficacy, or does this work to reduce anxiety in this clinical population? And again, these are by no means, I want to be very clear, these are by no means the only studies that have looked at anxiety, but these are the ones that lay the groundwork for using this as an intervention with people with diagnostic anxiety disorders. So the first study was published in 2018 by LIBOR collaborators, and this was the first study to look extensively at side effects in flotation rest, both negative and positive effects. And what they found, I know that's hard to see, but what they found is there were very, very few negative side effects, and those that were reported very mildly. They also found that there were far more positive effects than negative. Specifically, they found things like reduction in negative affect, reduction in pain, fatigue, sleepiness, depression, anxiety, stress, and increases in things like feeling refreshed and serene, relaxed, feeling more happy, feeling more energized. And in the second safety paper, which just came out in 2013, this was the result of the first NIH-funded grant, which was funded by the National Center for Complementary and Integrative Health. I dare you to say that 5 times. And this was a grant that was used to look at the safety in anxious populations, as well as practical things, that could influence float engagement. In this study, there were 3 groups. There were 2 pool groups. And the first pool group was kind of a standard treatment for float. It was once a week for 60 minutes for 6 floats. The second group had much more flexibility in their floating. They could float up to 2 hours, and they could schedule their 6 floats within a 2-week period, floating as frequently as just a 24-hour period in between each float. The third group was a chair condition, so the zero gravity chair rest condition. And what they found is that all 3 conditions had very few negative side effects. The differences came in that the pool groups had an increase in these positive effects. Again, down at the bottom, things like feeling relaxed, but peaceful, relaxed, and refreshed, as well as reduction in stress and anxiety. Additionally, as you're seeing here, the completion between the 3 groups was different, with the pool groups having higher completion rates than those that were in the chair rest condition, and the pool preferred group having the highest level of completion or adherence to our intervention that we prescribed. This suggests that flexible dosing could be important if we're going to use float in a clinical population. This is the first ever randomized controlled trial that was published in an anxiety population, and it was published by Johnson and Shelgren looking at reductions in anxiety in individuals with generalized anxiety disorder. They compared this to a waitlist control, so individuals not receiving any treatment. And that, again, is kind of the foundation of our work in research. And they found reductions in anxiety both mid-treatment, so halfway through, as well as at the end of treatment for individuals who are receiving float versus the waitlist control. Since then, 2 additional studies have examined if float works to reduce anxiety in these clinically anxious samples. And the first paper was a LIBOR paper which compared flotation-REST to viewing a relaxing nature video. What they found was that individuals in the flotation-REST condition had increased serenity as well as relaxation and reduced muscle tension and state anxiety. This next study that was, again, published recently as a product of that 2018 grant with those 3 conditions looked at the duration of the effect. What they found is that 48 hours after the rest condition, all 3 conditions, the float and the 2 pools, had reduced anxiety. 48 hours after their intervention. The difference between the groups really shows with the depression symptoms. All of the groups had reduced depression at 8 hours after the intervention, but only the pool preferred group had 48-hour effects for reduction in depression. Additionally, all groups had increases in serenity, but only the 2 pool groups had the increased serenity compared to baseline of 48 hours after the intervention. So again, this shows that in addition to the fact that there is something special about the pool that has both depressive and increased serenity, but the pool preferred group had reduced symptoms longer, and so suggesting, again, this kind of need for flexibility. One thing to note that's really interesting is that this pool preferred group, despite having the opportunity to float up to 2 hours, only actually floated on average about 15 minutes longer than the other group. So I think it's pretty safe to say, based on just these studies alone, that we have a solid evidence base for float as a safe and efficacious intervention for anxiety disorders. But what about, how does it compare to other interventions, and what about adaptation and implementation in the real world? And that's where I think projects like Maui Calm and Project Arcturus can be beneficial to us as a community. So Project Maui is taking a mobile float center and putting it directly in the epicenter of a large traumatic event, the Maui fires. And not only could that help us determine if there is a longitudinal benefit, like long-term benefits, are the individuals who are receiving this having lower levels of ultimate anxiety and trauma-related disorders, but it also gives us more evidence towards using this, again, in our community as an intervention. Project Arcturus, again, is collecting data from float centers like y'all's and looking at this as a generalizable research implementation. Like, does this actually work the same way in your clinics as it does in our lab? And that's really important to know as well. Finally, I think Project Arcturus, the ultimate goal is to compare flotation-REST to current kind of commonly prescribed anti-anxiety medication, which is another really important step in our process. So you can learn more about these by visiting the Float Research Collective, which is here this week. So my personal area of interest is anorexia nervosa, and now that I've talked about anxiety, I'd like to talk a little bit about some of the research that's being done with anorexia nervosa. There is a lot less research done on anorexia nervosa so far, but I'm going to talk briefly about the kind of foundational work that's been done. And there's more to come. So last year I talked about the grant that I had submitted to the National Institute of Mental Health. And this year I'm really excited to tell you that not only has it been funded, but it's been funded for 5 years. And, thank you. Thank you. Yeah, so I'll be doing lots of float research for the next 5 years. So it's been funded for the next 5 years, and we've already started data collection, which has been huge. It only took them 70 years from the time that Jay, Shirley, and John and Lily were there to fund something, but that's okay. That's another note. So I'm going to start with these trials, which really have to do with safety and efficacy before we jump into that, but I will talk a little bit about the grant and the upcoming data that we're collecting. Oh, that's my grant, sorry. Okay, so the first was a single group safety trial that looked at serious adverse events as well as orthostatic hypotension, which is a serious side effect or can be of anorexia nervosa in flotation-REST. The conclusion was that this is a safe intervention for these women. There was absolutely no signs of orthostatic blood pressure or adverse events. And they also looked at some secondary outcomes. The two that I'd like to highlight are the large reduction in anxiety from pre to post float. And this is important because, again, it's that replication of this effect in a different clinical population. The second thing I'd like to highlight, and I'm going to try to do it without advancing my slide, is this reduction in body image dissatisfaction. And this was really actually unexpected. We had no idea this would happen, but it's really clinically relevant because this is one of the hardest symptoms to treat of anorexia nervosa. This laid the kind of, again, groundwork or foundation for a randomized control trial. And all of these women were recruited for the Laureate eating disorder program. And this is an intensive treatment program for anorexia nervosa as well as other eating disorders. And each of these women were randomized to either receive usual care or usual care plus flotation-REST. I want to be clear about what usual care is because sometimes it means different things in different studies. In this study, it means that everyone was receiving 40 hours a week of inpatient therapy, so individual therapy, group therapy, nursing, nutrition, psychiatry, et cetera. The only difference between the two groups is that the flotation-REST group was also receiving 8 sessions of flotation-REST. So what did we find? We found that the flotation-REST group had reduced body image dissatisfaction compared to the comparison group. What you're seeing here on the left is the average across the 8 sessions, and you can see the float group in the light blue. And on the right, you're seeing at each individual session, we're seeing a reduction reliably in body image dissatisfaction. So again, we have this post-intervention reduction in body image dissatisfaction in the flotation-REST group in light blue. And perhaps what I think is more important and more exciting to see is that 6 months after 8 sessions of float, these women had reductions in body image dissatisfaction compared to the usual care group. So that led to this grant. So my current grant, I'm looking at float-assisted psychotherapy as an additive treatment for women with body image disturbance in anorexia nervosa. That's a lot of words. I am doing clinical exercises and teaching them therapeutic techniques while they're floating. So what does that look like? All I have, unfortunately, is a general overview because we just started with research and data collection. But all the women come from the eating disorder program. They're randomized to receive either mindfulness and acceptance-based treatment paired with flotation-REST, or mindfulness and acceptance-based treatments paired with skills videos. So I want to be very clear, these are both very active comparison conditions. The only difference is whether they receive flotation-REST or whether they're practicing along with skills videos. The other difference is the kind of the target of the treatment, where the individuals who are receiving flotation-REST are focusing their mindfulness and acceptance-based treatment on their internal body sensations, whereas those who are doing the skills-based videos are focused on the present moment. So I hope next year that I'll be able to actually present some preliminary data on this, because I have completed treatment with 5 participants so far. And what I've heard from the women in the float group is that the mindfulness treatment has helped them get into the pool, because they were very nervous about getting into the pool before. And it also helped quiet that mind chatter that we've heard a lot about or that we've experienced ourselves while they're in the pool. So I've talked about my research, I've talked about research in general. How can you use this in your center, in your marketing materials and things like that? The first step is to know what's out there. And you're doing that by being here. Float Conference has done a really nice job of inviting researchers like myself to tell you about what we're doing, and that's really exciting. There's also some tables outside with Chris, who has some resources for you about some of the research that's out there as well. The second thing that I think is perhaps most important is representing the research accurately. And why I say this is because it's easy to make lots of claims. If you can back those claims by science, it adds credibility not only to your float center, but it adds credibility to the intervention itself. And if the ultimate goal for some of you in the room is to have this covered by insurance, we need to have a credible intervention to get people into the float pool, but also to be covered by insurance companies. The next is testimonials versus research. As we know, testimonials can be incredibly powerful anecdotal evidence, and they can be really powerful in marketing. I just want to caution not to oversell those testimonials because they are one person's experience and they still need that formal investigation for research to back them. That doesn't mean I'm saying don't use them. I'm just cautioning in how you use them. But alternatively, if you can find research that backs those testimonials, think about how much more powerful that can be in your resource material. And then finally, I know this is easier said than done, but if you can collect data, if you can find researchers in your area that are interested in running studies in your clinic, that can help spread the word in the academic community. It can also help spread information about how this intervention works and how it generalizes in community settings. And that's maybe, perhaps, where some of the VA things that we just heard about could come into play. So, while the journey to our eureka moment or our big moment in Float has been long, we're now backed by 70 years of research history, with our progress bringing us closer each day. So with 2 NIH-funded studies now, and hopefully more to come, there is more and more financial support to study Float in the academic research field, and there's lots of interest in terms of people, new research groups coming up each year who are wanting to study flotation-REST. So we're not treading water, I promise. We're actually floating along towards our ultimate goal. I'd like to thank my collaborators, so everybody at LIBOR, as well as my research team, who without this wouldn't be possible. And I'd like to thank you all for your time today.